There are a huge array of medical dynamics that people endure, and when they leave a lasting impact, a word that we don't use widely enough is the word trauma. There's an entire category of phenomena in the medical arena that are, in fact, traumatic. One way we know that these experiences are traumatic is that we know that huge portions of people who experience things like cancer do indeed develop problems like PTSD.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with James Jackson, Research Professor at Vanderbilt University Medical Center in Nashville, Tennessee, about understanding medical trauma in oncology. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Welcome and thanks so much for joining us today, Jim.
Really good to be with you, Jamie. Thanks for having me.
Our discussion today is about medical trauma in oncology. We know that going through a cancer diagnosis and cancer treatment can be truly a traumatic experience for our patients, for their families, as they face uncertainty, loss of control, or even ultimately fear of death. And some of them potentially develop lasting psychological effects, including post-traumatic stress disorder. So can you give us a definition of what is medical trauma and what are the symptoms that we might see our patients experience if they develop this? And maybe just give a little bit of context of how prevalent is medical trauma for our cancer survivors.
Many people have a notion about what medical trauma is, but perhaps they lack a definition. I use a definition that is deliberately broad because I think it is better to be inclusive, if you will, than exclusive. Medical trauma to me is a medical experience or a medical encounter that basically leaves a mark. It leaves an emotional mark, and that mark is significant enough to disrupt your daily life. When I say a medical experience, I mean by that the experience is you've developed cancer and now you're living with cancer. You've developed Parkinson's disease, now you're living with it. Or perhaps it isn't an illness like that. Perhaps it is that you have become acutely ill and now you're in the ICU. You've been fighting for your life. Perhaps it isn't even something that involves you directly. Perhaps it is that a family member has developed cancer and you are watching that, not from the sidelines, but up close. And it really is disruptive. There are a huge array of medical dynamics that people endure, and they are hard to varying degrees, and they leave a lasting impact very often. And when they leave a lasting impact, a word that we don't use widely enough is the word trauma. For too long, I think we have used trauma correctly to define things like combat and sexual assault. Of course, those things are hugely traumatic. No one would debate it. But there's an entire category of phenomena in the medical arena that are, in fact, traumatic. Cancer would be one that people often point to. And one way we know that these experiences are traumatic is that we know that huge portions of people who experience things like cancer do indeed develop problems like PTSD. The rates, the numbers, they range a lot, but they are vastly more common, these PTSD symptoms, in cancer survivors than they would be in the general population, for instance. And Jamie, they are incredibly disruptive. These symptoms are incredibly disruptive.
Are there any patients that are at most risk for developing or experiencing or having medical trauma? And are there any factors that put patients with cancer at greater risk for medical trauma, say, than other types of either chronic conditions or other sort of medical episodes they might experience?
Just yesterday, I was in the ICU at Vanderbilt seeing patients, as I often am, a couple of days a week. One thing I find there, this isn't new news to you. This, of course, is logical, it's reasonable. One thing I find there, and one thing the research bears out, is that if you develop cancer, let's say, when you're 85, that's one thing. If you develop cancer when you're 25, that's quite another. In situation one, we still don't want an 85-year-old to have cancer, right? It's a hard thing, but often those patients experience it very differently. They have lived perhaps a rich life. They have been contemplating death for some time. Their parents are gone. Their partner may have died. They have already lived a long life. So often they experience medical trauma very differently. It's less impactful than it is for a 25 or 35-year-old who has big plans, who has little children, who perhaps is newly married, who is on the very beginning, just on the cusp of this life they plan. So age is one big factor. The younger you are when these problems develop, the more likely they typically are to be experienced as traumatic. The other thing I would say, and I think this is really logical, is medical trauma develops in relation partly to how much trauma you've had prior to experiencing, let's say, cancer. If you already have an anxiety disorder, if you've had multiple traumas, when this primary trauma lands on you, that makes you vulnerable. Those would be two big things I would say. Age is a risk factor, and your previous mental health struggles or your previous experience with trauma. The more trauma you've had, the more likely you are to hit a tipping point when you add one more big trauma that often moves you into this place of developing PTSD or really struggling.
I think those make a lot of sense. And to me, it's all about sort of context of like, what is the patient's experience and context of their life when they are having this potentially medically traumatic experience? And so that can kind of set the stage of how it will impact them and what are their coping mechanisms they already have in play. So I think that's just great information for us as oncology nurses to think about as we're meeting maybe a patient for the first time, of really understanding like, what is the context that this patient is now experiencing this new diagnosis in, and how do those factors either, help or hurt their ability to kind of cope with the experience they're going through?
I think context is always so important, not only in the context of understanding the experience of patients, but also understanding the experience of families. So a 50-year-old adult child of an elderly fellow, an elderly man or an elderly woman who is dying from cancer at the age of, again, 80, that 50-year-old is grieving, perhaps they're weeping, they're struggling, but their experience as a family member is very different than the experience of a parent of a young child who is grappling with the new emergence of cancer. For the adult individual whose older parent is dying from cancer, there's a normalcy to this. There's an expectation, there's an awareness. For a parent whose young child is dying of cancer, there's a sense that, gosh, this is not the way the world is supposed to work. I'm not supposed to be in this situation where my child is potentially dying. So for them, it's dramatically more traumatic. And I think as it relates to families, there's another point to make, and that is that when somebody develops a life-threatening illness, again, let's say cancer, it's not their problem only. It's very much a family problem. It affects any manner of people. There is literature that says that family members of people with life-threatening conditions often have rates of PTSD that are every bit as high as the patients do. There's also literature that says that if we can identify this issue as a family problem, a family challenge, not just an individual challenge, then very often that patient is going to do better. When your partner says, this isn't just you, honey, struggling with cancer, this is us now. I'm taking this on, it's mine too. That's really empowering. It's really hopeful. And often it leads to better outcomes.
Do you feel that medical trauma is sometimes overlooked in oncology? And are there any signs or, things that we as nurses should be watching for so that we don't overlook them? We can identify this possible distress without ignoring it?
I think it's vastly overlooked in oncology, although, full disclosure, I think it's vastly overlooked everywhere. One reason, perhaps, in oncology that it's overlooked is that to a certain extent, when patients have finished a course of chemotherapy, let's say they've had a great outcome and, maybe they're on a hospital floor where they ring the bell, they're cancer free. Often patients feel a certain pressure, and it's not external necessarily, it's often internal, but they often feel a certain pressure, I think, to be expressing a lot of gratitude for the care, for the engagement, for the outcome they're now living on cancer-free. They feel a pressure to experience and display some gratitude. And often in focusing on gratitude, because they feel like they have to, they're a little bit reluctant to articulate how much they still might be struggling because they feel like that means I'm not really thankful for what you did for me. I'm not really appreciative. Some percentage of people with cancer, as well as other conditions, they're reluctant. Transplant survivors would be another good example. They're reluctant to raise their hand and say, I'm having a hard time, because they feel like that invalidates, crosses out the gratitude that they're supposed to feel. They sometimes have a hard time making space for the negative feelings they're having.
That's so important. And I think such a great perspective to keep in mind. I just think that it is something that even as society, I don't know that we are as a whole comfortable talking about death and cancer. And you see a lot of, when you see things on social media of like, oh, you're going to fight it, you're going to stay strong and don't give up the fight. And like just that whole narrative and all of the words that are used, like just adds a lot of extra pressure, I think, on patients as they go through their experience. And when they come out, hopefully maybe on the other side, whatever the other side really is for them, it does put a lot of pressure on them of how they perceive what they've gone through and how they feel comfortable and sort of moving forward in this phase of their survivorship of what that looks like for them. So I think all of this discussion is just really important for us to consider of how unique that experience can be for every patient on not only what they've gone through, but how they are able to kind of cope and sort of move forward in their life with the state of how they've ended up through their cancer diagnosis.
Very well said. You mentioned the word survivor, and I think I have mentioned the word previously today as well, survivor. I think the words that we use matter. Some time ago at Vanderbilt, we did I wouldn't call it a study. I don't think we published it, but we asked our patients, what exactly do you like to be called? Do you like to be called ICU survivors? Some of these patients survived, in quotes, the ICU with cancer. Not all of them had cancer, but the question again was, what do you want to be called? Do you want to be called ICU survivors? They are technically, I suppose, ICU survivors, if by that we mean they're no longer in the ICU. They made it out of the ICU. But many of them express that they don't necessarily love that term, survivor, because I think that term carries for many people a certain amount of baggage, and it carries a certain amount of pressure related to you're strong and you're sturdy, you're a warrior. Some people embrace that, and some people say that introduces a little bit of pressure. And I don't know that I was particularly strong. I think I was just doing what anybody else would do. There's a lack of clarity among patients, I think, about what they want to be called. I know many of them know what they don't want to be called, survivor. Some of them will say, I'm not exactly sure what I do want to be called. They have an internal struggle with this. I think a simple clinical intervention is to simply say, hey, I've been calling you a cancer survivor. Is that helpful? Is it not helpful? The narrative that I'm engaging when we're talking is that you're really courageous and brave. Am I inadvertently adding some pressure to you? Is that something that isn't helpful? Just being curious about that, I think, goes a long way, because sometimes there is a mismatch, I think, between how we describe patients and honestly how they want to be described.
I think that is so important. And as you just said, not really a hard question or conversation to even have, of just to ask it, casually, but intentionally, of like, this is the word that some people like, but many people struggle with or just don't prefer it. And so just understanding if that term creates any problems or concerns for the patient versus if it's helpful. And I think it can be as simple as just asking if they like that or not. It brings up for me, probably could be a whole separate episode, is, I think sort of a recurring kind of question debate that we see in sort of the oncology space is the ringing of the bell. And what does it mean to ring a bell and be done with treatment and be a survivor? And I think in the same thing that we've talked about, like, is that experience, not only is it helpful for the person who is offered that bell ringing experience, but what does that then do to the surrounding patients, the surrounding families? How does that contribute to their overall experience? And does it contribute to any feelings of sort of distress or trauma, because it is connected sort of to the overall experience?
I hate to poke at something that on one level is so beautiful, so iconic. And yet, I do think sometimes that act or any act, ring the bell, it can sometimes imply, I think, that something is over when it's not exactly over. Yes, like we can affirm what a blessing that someone is cancer free now or they've finished their treatment, the cancer's not returned. Like that is something to celebrate. I'm sure there are effective, better, worse ways, whatever to celebrate. But many of our patients in so many disease states would say, it's lovely that I don't have cancer on a scan. It's amazing that I'm no longer in the ICU. However, the idea that my journey with this is over is not exactly the case. And I do think that's what we need to really emphasize. And I think we can be gentle, but also clear about that, about the idea that, yes, sure, people don't seem to have any more cancer. And yet the anxiety that they have over future scans is active and real. The impact that their cancer had on their family, on a son or daughter who developed depression or an anxiety disorder, on any manner of dynamics, those issues are not over. I've used the word making space earlier today, I did, but we just need to make space for people to feel however they feel. And we need to emphasize, I think, that in some ways, even though there's no cancer on the scan, cancer casts a long shadow in the lives of people, which is why when patients after cancer see their primary care provider, when they come back for a checkup with oncology, we need to continue this conversation of how is your mental health? Are you okay? How's your anxiety? How are you managing? Instead of putting this experience in a box and saying, we're going to tie this up with a bow because I had a good outcome. It happened 3 years ago now. So I'm not going to engage it at all. Well, it doesn't need to be engaged constantly, but we need to be really curious and kind. And we need to query people about how they're doing, even if officially they don't have cancer.
Absolutely. And I think speaking as a nurse who's been lucky enough to witness some of those bell ringings and some of those celebrations, I think that for us as nurses, it is always a very complex emotion that we experience when we see our patients do that, because we do want to balance the excitement and the celebration and the hope for them that this is the end of maybe their treatment journey. But as you said, even in that best case scenario where they are cancer free and they remain cancer free, there is still a journey for that patient to move through in terms of coping with what they've experienced. And we know that that can still hold challenges for them. We as oncology nurses often witness the distress and the suffering and even end of life care that our patients go through. What are the psychological effects that nurses experience from working in this potentially traumatic environment as well?
I think it hits at the heart of the issue, which is that in oncology and in other conditions, it's not only patients that are affected by the dynamics of battling with cancer, it's healthcare providers as well. Nurses, I think, particularly because they often are the frontline providers that are spending the most time with patients. They're not having a one-off visit with a patient every month necessarily. They're at the bedside, often 24/7. Nurses, young or old, are vulnerable to developing problems like anxiety and, in some cases, PTSD, depression. I think that can develop in the context of a number of scenarios. I mean, one of them is at a certain point, if you're a human, which nurses obviously are, right? If you're a thoughtful human and you're exposed to enough of a burden of witnessing and experiencing trauma, it's going to affect you. We should acknowledge this. I used to work very regularly with combat veterans with PTSD over 21 or 22 years, not as a nurse, but as a psychologist. And during that time, I heard thousands of stories of trauma. I don't know at which point the trauma started sticking with me, but I was aware that at some point early in my career, it seemed easier to sort of shake it off. And at a certain point, I remember thinking, gosh, these memories, these stories, they're staying with me now. They're lingering. There's a cumulative burden. It's really harming me. And I think that's the story of many nurses, that for the first year or two of this work, maybe the volume of exposure to trauma is modest enough that you can shake it off. But at a certain point, it's hard to shake it off. When you get to the point where it's hard to shake it off, And that might be manifest in things like you're having problems sleeping, and the stories of these patients are looming a little too large in your memory, and you're pretty irritable, and maybe you're relying on some methods of coping that are pretty maladaptive. Maybe you're drinking a couple glasses of wine at night instead of one because you're really feeling overwhelmed. When these sorts of things happen, often that is a blinking light that says something's going on emotionally for you. This trauma is sticking with you. It's time to engage it. When it is time to engage it, when symptoms are emerging in the life of a nurse that would suggest it's time to engage it, it's best not to wait. Don't wait until that blinking light turns into a red light. Talk to somebody, get some help, right the ship, and if it's appropriate, get back at it. But don't suppress the struggles that you're having, because eventually their effects are going to catch up to you and it will be really harmful for you. Does that make sense?
Absolutely. Over the years of my experience in practice and, onboarding new nurses to oncology, I think the sort of the instinctual hesitation for a lot of nurses to go into oncology is, oh, it's always so sad. And then we, as the experienced oncology nurses, say, oh, but it's not that bad. We sort of couch it in, yes, it is sad, but there's also this great experience of working with patients and seeing them through this journey. And all both are absolutely true. But I think hearing what you've just said, wouldn't it be a great middle ground to say that it can be very sad, and not just sad, but distressing. You might be fine, but during your career in oncology, you were likely to experience some of these distressing situations. At some point is likely to catch up with you and to feel very heavy. And couldn't we set up and insert the expectation that these are the resources that we want you to know and tap into early and often, so that we can support you as nurses for a long career in oncology, and not just hope you turn out okay. And if you struggle, then it's on you to raise your hand and say you need help. But how do we create systems to support nurses, and not just oncology? As you said, there are plenty of other subspecialties that are equally, I think, exposed to repeated traumatic experiences with their patients. And so how do we set up a structure that supports nurses and other clinicians to say, this is hard work and we want you to stay in it. So how can we create these systems to support you proactively and not wait until it's gotten too far? And I think part of what we saw out of COVID, I think, highlighted the traumatic experience that being a healthcare provider in certain environments can be.
Well said. And no doubt we need to be proactive. My wife, Michelle, and I, we moved to Nashville in 2000 from California. And we had one car. I was the one who was driving it one day when the check engine light came on. If my wife had been in the car, we would have handled this differently. But for me, the check engine light came on. I was too busy to attend to it. And I think I thought, man, something's wrong with the car. We can't afford to fix it. So I had a Post-it note, like this is a true story, or a note card or something. And I just covered the check engine light and I just kept on driving. I remember thinking, problem solved, like this is amazing. So I kept on driving. And one night, some months later, I was out in West Nashville and the car started smoking, started shaking, broke down by the side of the road. The next day I sold it to the scrapyard. There was a scrapyard and I sold it. I think it was for $50. It's a very frustrating situation. It was a lesson in the importance of not ignoring things. The car wasn't worth much. It was worth more than $50, but the mental health of a nurse and the life of a nurse is worth vastly more than a car. And the impact of being derailed professionally and personally by the trauma you're enduring, the impact is inestimable. So, I would invite the listeners of your podcast not to do what I did. When they start noticing changes, and the key is changes, it's time to seek help. If you're a cynical person, but you've always been cynical, then that's not a change, right? I'm not particularly worried. But if you moved into nursing very hopeful and now you're very cynical, that's a change. If you've always been irritable and now you're irritable, that's not a change. But if you're suddenly becoming hugely irritable and you weren't before, that's a change. So the things that we pay attention to in particular, are there changes in your behavior? Are there changes in your mental health? Are there struggles that are new? If so, address them. One thing I often recommend to people, to healthcare workers, and I think this is quite a good idea. Many people, I think, have not thought of it. I recommend that they reach out to a counselor or a psychologist even before they need it. to form a relationship and to say, I'm in this stressful occupation, I'm doing pretty well. And if I'm not doing well in the future, I don't want in that moment to have to try to find a mental health provider. I would rather have one sort of at the ready, just like I have a PCP. So, can we establish a relationship? I'll become one of your patients. Maybe I'll check in once a year or some such thing, but I'll know that you're there. And that will be really helpful because then if everything hits the fan and I start struggling, I won't have to go through the difficulty of finding a provider. I'll already have one. I actually think that's a great idea.
I really do like that. I think that's a great approach of kind of establishing that relationship up front so that if and when you start to struggle or notice these changes of that you can tell maybe are a sign of something bigger, you're not trying to form a relationship in the midst of that struggle as well. I think that that's a great recommendation for nurses to consider. What resources do they have that they can tap into and kind of establish so that when they need them and when things are maybe feeling especially challenging, they don't have to also overcome the burden of taking those first steps because they've already done that. That's great advice.
And I think the other thing I would say, there's certainly an emphasis in nursing on self care, and people get coupons to have manicures, or I don't know if people use the word coupons anymore, but people get gift certificates to get manicures and pedicures and go to a spa. I very much would not denigrate that at all. That's fine in minimizing the effects of a day-to-day stressor. But if you're now in the midst of a emerging episode of depression, if you now are on the cusp of developing PTSD, the sort of self-care that we often talk about, just take a walk in the park, listen to some music, hang out with friends a little bit more, that's not really going to move the needle much on a real clinical syndrome. I mean, these are important rhythms to build into your life. I actually think they're hugely helpful, but they are not hugely effective when you have developed a real clinical condition. So while I love it when nursing managers support self-care, I think perhaps an even more important thing would be that nursing managers, nursing leaders model vulnerability about their own mental health struggles, and in so doing, give nurses permission to do the same. That, I think, is the key. The self-care emphasis, very fine, not wrong. But more important, I think, is creating a climate where mental health struggles are destigmatized and where nurses feel like it is safe to go to a manager and say, I'm really having a hard time here. What can we do about it? Too often, PTSD, anxiety, depression, OCD, you name it, there's still such a stigma around that people are reluctant to be vulnerable. That prevents them getting the help that they need. And we need to change that, honestly, Jamie. We really need to change that.
I want to stop right there because that's the last word, but I've got a couple more questions. So pivot just slightly. Can you explain so this term I've heard frequently, trauma-informed care. Can you explain what trauma-informed care is and why it's important in oncology?
Trauma-informed care has become a bit of a buzzword in our culture, but when it is engaged correctly, I think it's really important. And I think in a nutshell, what it means is that as providers, we need to recognize that some situations and circumstances are likely to be traumatic, and we need to pivot and engage people differently now that we know that. Specific features of trauma-informed care might be, hey, we're really going to value your emotional safety. We're going to emphasize that. We are going to emphasize boundaries. We are going to ask your permission instead of telling you how to do things. We are going to be really attentive to the language we use to engage you because we're aware there might be things about your situation that are really triggering. We're going to include your family in really pertinent and painful discussions because we know that if they're not there yet, it might be really traumatic to you. It is acknowledging that there's this trauma swirling around and pivoting to be really thoughtful in the way we care for people as a consequence. That's really trauma-informed care.
And there are some examples. Can you provide just some practical ways that nurses we can apply some of those trauma-informed care principles to help build that trust with our patients and their families, really to create that safe, empowering environment for patients and caregivers along the whole trajectory of their care?
For example, There are many situations where there might be news to deliver to a patient, and maybe the patient is there by themselves, and maybe is going to be really alarming for the patient to hear this difficult news without any support. So it might be appropriate to say to a patient, we've got some challenging things that we need to discuss today. Is your husband on the way? I know you want to talk about this now. Let's wait until your family arrives. So integrating family would be one thing. Taking a trauma history would be another, so that we could be attuned to whether what we were doing with a patient might be re-traumatizing. Those are simple sorts of things that somebody could do, but just really being mindful of the fact that what we're doing could trigger people. What we're doing could be harmful rather than helpful. Just really having that at the top of our mind so that it could inform how we engage.
Well, Jim, I really appreciate your time. I feel like we've just scratched the surface on this really important topic that I think nurses are hungry to learn more about. And so I look forward to being able to continue this conversation, hopefully on a future episode with you. But as we reach the end of today's episode, we'd like to run through a series of some wrap-up questions just to help us emphasize some of the key points that we've touched on. And so to start that off, how do you think healthcare professionals can evaluate their hidden or implicit bias that they might hold about medical trauma?
I think the first and crucially important thing is to recognize that we have biases, right? I mean, it's a little shocking to me in 2026 that this is a novel idea in some places, but it is. I mean, I think some people are not really fully aware of what their biases are. So the first thing I would say is let's begin to be curious, right? Let's be curious about the possibility that we have some biases. I'll share one that I had for many years. I had a bias, which was unless something is really big and scary, I don't really think it can be traumatic. I believe that as a young psychologist. That happened until about 20 years ago. I got stuck on an elevator one day, just simple thing, stuck on an elevator in Albuquerque, New Mexico at a hospital. And I had a panic attack. And honestly, it completely derailed my life. I developed really severe claustrophobia. I stopped staying at hotels where I couldn't walk up the stairs. I stopped riding on rides at amusement parks with my kids because, I had to be locked into a roller coaster. I was really claustrophobic. This little thing, this little experience of being stuck on an elevator, it became really profound to me. Point of that story, Jamie, is that taught me that little things, tiny things, can actually have a really big impact. And I think all too often, providers have some notion of what sort of illness or experience should be traumatic and what sort of illness or experience shouldn't be. And I think that leads to being compassionate toward patients in the should be traumatic box and minimizing the experiences of patients in the shouldn't be traumatic box. One bias that I would love us to engage in this bias where we say, you know what, if I think something is traumatic, that means it's traumatic. If you think something's traumatic, I don't think it's traumatic. It's not traumatic. Let's let go of that. Let's stop separating things into big T and little t. Let the biases go. Let's empower our patients. And if they think that some aspect of their cancer journey is traumatic, let's just receive that. Let's assume it is true. That's one bias that we could be curious about that I think we could change.
And kind of along those same lines, what are some common misconceptions that exist about medical trauma?
I think one certainly is that it is only afflicting and affecting people who are frail or weak, not very strong. That's emphatically not true. But that's a popular misconception that if I'm strong enough, if I'm resilient enough, this experience will not be traumatic to me. It's just not true. Medical trauma doesn't just happen in emotionally weak people. Medical trauma can impact people of all sorts. The other misconception, I think, is that there is no hope for people in the throes of medical trauma. I'm not advocating hopium. It's a term that was coined, I think, during the pandemic. I don't think that living with medical trauma is all rainbows and unicorns and shiny things. But the truth is, if you get the treatment, Jamie, that you need, you can find a way to thrive with medical trauma, even as you're impacted by medical trauma. This both andness is really true. You can both be adversely affected and you can even find some beauty in your struggle. Both can be true. So the two things, one, you don't have to be weak to experience medical trauma, and medical trauma, thank God, is not the end of your story. It does not have to be the end of your story.
What's something about this topic that's not often discussed, but you wish people knew more about?
I wish people understood just how common this is. I wish people understood that there is a name for this phenomenon. We're naming it here today, medical trauma. Not everyone who has cancer has medical trauma, not even close, but there are many people who do. And I think many of those people, they don't quite have a name for it. And when I introduce this name for it, trauma, many of them say, oh my gosh, that makes so much sense. I didn't quite understand why I was struggling so much with this. I didn't quite understand why it cast such a long shadow in my life. I didn't really understand why I was having panic attacks every time I had to get another scan at the oncology office to see if my breast cancer had returned. Now I understand. Now I understand. It's because it was trauma. I don't advocate the idea that trauma is hiding behind every bush, that it is under every rock. Of course not. But it's common enough. I think patients need to be invited to consider the possibility that that term applies to them. And in many cases, the truth is it does. And when they realize it, the story of their life, Jamie, makes a little more sense.
That validation can sometimes be the catalyst to moving towards treatment and healing from that trauma, for sure.
Absolutely. The validation and the affirmation is so important.
And what additional training or education would you recommend for oncology nurses so they can stay current on this topic?
There are increasingly presentations at conferences, specialized trainings on the topic of medical trauma, CEUs that are available for people in the oncology field or ICU field or whatever it might be that intersect with medical trauma. If those sorts of opportunities are available, people should pursue them. There are some books available. I've written one, Reclaiming Your Life from Medical Trauma. There are others. I think a simple thing to do if you're working on an oncology floor and in the context of that work, you're rubbing shoulders with a social worker, you're rubbing shoulders with a psychiatrist who's consulting. If there's a psychologist on the unit seeing patients, bend their ear a minute, just talk to them about this idea of medical trauma. See what you can learn from them. I think those are simple things that nurses can do. And above all, be curious, right? Be curious about the experience of your patients. Don't be afraid to ask the questions. For too long in the realm of suicide, there was this idea that if I ask a patient if they were suicidal, that would somehow make them suicidal, that they would be more likely to kill themselves if I asked them about suicide. There was this gigantic misnomer. Of course, it's not true. I think perhaps there is this idea that if I ask my patient if they're grappling with trauma, that will somehow also be harmful to them. What I would say is if you're concerned about the mental health of your patient, ask them about it. Just ask them about it. If they express some difficulty that they're having a struggle, invite a chaplain into the picture, invite a social worker, invite the psychologist on your unit, whatever. But don't shy away from the curiosity that you need to have about this topic. Far too often, we have ideas about what patients experience as problems. And often patients say, your notion of what is really bothering me, that's actually not the thing that's really bothering me. And what a lot of our patients will tell us is that these mental health struggles, sometimes they're worse than the medical side effects of chemotherapy, let's say. There's some number of people who would say, yes, I don't love my hair falling out, but what really bothers me is the anxiety that I have now. What really bothers me is the nightmares. What really bothers me is the thoughts that I'm not going to get to see my daughter graduate from high school in 3 years. And gosh, that is haunting me, keeping me up at night, making me chronically anxious. So let's make sure, in the words of Stephen Covey, the great strategist and thinker, let's make sure that the ladder we're climbing is leaning against the right wall, meaning we are addressing the issues that patients have. Yes, medical outcomes are important, but many patients would say that their mental health outcomes are every bit as important, that the mental health distress they're enduring is every bit as much a problem as the pain they're having, as the side effects of chemo. Let's treat it accordingly, Jamie.
Well, Jim, thank you again for coming on our podcast today. Such an interesting and so relevant topic to oncology nurses and the patients that we care for. So I really appreciate your time and look forward to going a little deeper on this topic in a future episode. Do you have any final comments to share with our listeners today?
Just that I appreciate you shining a light on a problem that doesn't get much attention. I think we're going to be better in oncology if we recognize that mental health is health. It's not siloed. It's not a different kind of health. Mental health is absolutely a part of health. We should treat it accordingly. And I think today you and I have invited people to do just that. And that makes me really happy.
Well said. Well, thank you again, Jim.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.